So, welcome to Healthcare for All Washington's monthly speaker series. This month, we welcome our ally physicians for a national health program. Their members are quite supportive of what we're doing, and there's a real overlap of members on our boards and our leaders. My name is Ronnie Shure. I volunteer as president of the board of directors. And tonight, I ask you to join us as a trip back to the 1970s, to a time of freedom and social upheaval in Seattle and across the country, a time of struggling for civil rights, a time of opposing the war in Vietnam. So, Bruce Miyahara will be telling us a story about social justice and democratic organizing story that's behind the founding of a small clinic in Seattle's International District. Uh, Gary Goldbaum will help Bruce lead this discussion. So thank you for joining us tonight. Like me, you too can volunteer for Healthcare for All. Please consider doing that. We have a policy committee, a communications committee, a fundraising committee, an outreach committee, or just join for a specific opportunity or give us some advice. We really enjoy getting that advice. In the Zoom chat section, we will be posting our website. You can go there, find the donate button on our website. You can navigate to a button that says get involved, and that will help you volunteer to join one of those committees or offer your advice. While you're on the website, please make a donation if you're able. Every donation helps us move closer to universal health care, further along that pathway. We have set a goal to raise $250 during the program tonight. So I'm participating in this Zoom meeting tonight from the lands of the Coast Salish peoples. Please take a minute to acknowledge people in the lands where you are joining us today. We acknowledge all the ancestral homelands and traditional territories of indigenous peoples who have been here since time immemorial. Unlike our current national leaders who are selling off our lands for profit and possible destruction, we respect the efforts that our ancestors made to preserve our lands, the lands of the Coast Salish peoples, the border and touch the shared waters of all tribes and bands within the Duwamish, Muckleshoot, Puyallup, Suquamish, and Tulalip nations. So, Ron, let's get rid of that background and bring up Bruce and Gary. Tonight's speaker, Bruce Miyahara, will be sharing the founding story that led to the growth and development of a large health service, the International Community Health Services, who provide culturally and linguistically appropriate health services in 11 sites in Western Washington. And with a little help from our friend Gary Goldbaum, Bruce and all of us will explore this International Community Health Services vision of healthier people, of thriving families, of empowered communities, and a just society. You may remember that in May, Michael Fine, who leads a single payer organization called Primary Care for All Americans, inspired us with his national vision of community-based and community-organized primary care clinics. You can catch Dr. Fine's presentation on our website. Healthcare for All Washington actually has a YouTube channel that you can Google. Watch Dr. Fine's presentation. I had like the opportunity to serve as a pharmacist on a quality assurance team in public health, Seattle and King County when Bruce was the deputy director there. He was such a powerful voice for public health in our community and a valuable personal mentor to me and many other public health leaders. From 93 to 98, Bruce also served as Secretary of Health for the Washington State Department of Health. While they were developing their international or their initial public health improvement plan. He's currently a public health management consultant. He works with Northwest Public Health Primary Care Leadership Institute at UW, and he calls himself a foodie now. He has a role as a part owner and a cook at Haniatu, a Japanese restaurant near me, a Japanese restaurant in Fremont. We also have Gary Goldbaum, who was a health officer and director of Snohomish County District Health District from 2007 to 2017. He's a family medicine doc, preventive healthcare doc who's worked with CDC, whatever that is. Hopefully, it still exists years from now. But also the state health department, and we worked together at Public Health Seattle and King County, where he directed the HIV/AIDS epidemiology program. Was such a value to be a part of that, and the other work that I've had the opportunity to overlap with Gary, both at Public Health and at Harborview. And then he went on to Snohomish County. I think you had to get a passport and move up there. And currently uh, is a professor emeritus in epidemiology at the University of Washington. Gary is not a part owner of a restaurant. He is not a cook, but he really enjoys Japanese cuisine. I mean, he went to Japan recently for that very purpose. So why don't I let Bruce and Gary take it away and start our program? Thank you all for both for being here.
Thank you, Ronnie. Thanks for that introduction. And I'm going to, I'm not going to make a lot of remarks. I just wanted to let everyone know that I'm going to try and guide a conversation through history because Bruce has a lot to share with us. We're only going to speak for about the next 25 or so minutes, and then we'll open it up for questions. So let me take us all back. Bruce, if you wouldn't mind helping us to make that connection between primary care, community, and how that all leads to better health generally. We're talking today about universal health care, and we think that there are lessons to be learned from your experience organizing in primary care so many years ago. So maybe I could start by asking you, could you share with us what the environment was in 1975 when you were starting out looking at what was happening in the community and you started the whole process?
Well, hello everybody, and thanks, Gary and Ron. You should be doing some podcasts, I think. Going back, it was not really 75. I'm thinking going back to about 72. And I think it's the convergence of a lot of different issues and systems. And I think there's a couple of things going on. I was in a band at that point in time. I got out of high school and we had a dance band, a rock band, and played around the state. Then I said, oh, I got to get serious. So I got back at the U and got back into a pre-med program. About that time, many of you know there was a free clinic movement in many areas of the country. And a group of physicians and residents in Seattle worked with a physician on Beacon Hill private office and started a one night a week volunteer clinic that was called Asian Community Health Clinic. And it was just a voluntary effort, primarily to address potential income barriers and language and cultural barriers, primarily with the Asian community. Well, once I quit the band, I had looking around for something to do, so I started volunteering at the Asian Community Health Clinic, and actually started running and helping the volunteers, helping organize it for once a week. At the same time, I was also pretty involved in the International District. And for people who are not familiar with Seattle, International District is an area just south of downtown, where through history, primarily a Chinatown, a Japantown, and a Manila town all sort of grouped together. And it had been under threat for many years. The Japantown area sort of deteriorated when my parents and all the Japanese in the area were basically resettled in concentration camps. So that sort of killed the Japantown area. And then right after the war, with Eisenhower putting the freeways in, I-5 cut the international district literally in half. The eastern portion of the district sort of withered, and then the western area was just trying to get settled and rebound. That happened to be where the King County decided they wanted to build a domed stadium. And the domed stadium was right next to the international district. And there was a lot of community efforts to save the international district, save the hotels that were there where many of the elderly Asians were living. And a lot of demonstrations and things were going on. I was down there helping in the International District Improvement Association. Some of you may know the name Bob Santos. He was kind of like the godfather of the International District. And he was helping organize saving the community. And we had a lot of demonstrations when the Kingdom was being built. We sat in, and the county executive's office and city council and everywhere we could, and managed to get a little bit of funding to start a health program. At the same time, Harborview Medical Center, which is the county hospital, which is run by the University of Washington, opened a Pioneer Square neighborhood health station. And it was the intent to serve the Pioneer Square area as well as the International District. Well, what wasn't happening was the International District residents were not really feeling comfortable with the Pioneer Square residents, so didn't use the facility. Some of the staff came into the International District and opened an occasional clinic there, but it just didn't run very smoothly. So Bob Santos said, let's build a clinic here. We've got some funding to deal with health services in the International District. And you are running a volunteer free clinic up in Beacon Hill. Why don't you bring it down here and we can get started? And so literally, he put me on interim staff, and we looked around for a facility, and right across the street from his office, there was a gambling hall, primarily a Filipino gambling hall. And he managed to talk to the owners that were leasing it. They said, oh, okay, you can have it. So we took over the facility and then started to run the free clinic down there. And literally it started out with little exam areas. We had some tables and hung some blankets in between the exam areas and started to do the free clinic, then got a few more staff. And Sister Heidi Pereño, who was the nurse practitioner at the Pioneer Square Health Station, received a nursing demonstration grant where she had a nursing staff in 4 different languages that became part of the start of the International District Community Health Center. They were literally doing outreach in the community and going to the hotels and doing checkups or whatever in that facility, as well as coming back as we added physicians to the International District Clinic to see the patients. And basically started to attract more and more funding, and it grew and grew. And then in 1975, Vietnam resettlement program started. And I went out to Camp Murray and welcomed the first group of Vietnamese into the area. And what started out as International District Community Health Center began to expand to the International Community Health Services. It was no longer geographically confined, but was dealing more with language and Asian language and culture issues county-wide. Parallel to all of that, another system that was connected, we we're working with the Country Doctor Clinic and Carolyn Downs Clinic. They were also early free clinic startups. Country Doctor probably, I would think it's probably the first one that started maybe in Seattle up on Capitol Hill. And the Carolyn Downs Clinic was the Black Panther breakfast and health clinic. And well, we created a consortium, which was uh, the Central Seattle Community Health Centers. And that was a group of health centers in Central Seattle that worked towards starting to get some federal funds in. We also did a kind of a weak analysis, but it worked, called around to all the physicians and got checked to see how many would accept Medicaid. And at that point in time, there were very few. And we used that argument to bring the National Health Service Corps into Seattle. Senator Magnuson gave us the ability to try that project, and we had to work to get the medical society to agree, which wasn't easy. We had to formally get them to agree to this, and they, at that point in time, they held their meetings in the Washington Athletic Center, which was a heavy-duty, high-rate, members-only club, and we had all of us looking like either hippies or minorities coming to the front door, and they literally asked us if we wanted to go through the service entrance. So it was that bad back then, but we got approval from the King County Medical Society and started having National Health Service Corps docs in the Central Seattle Community Clinics. So that's about when the federal relationship started. We got some, well, I think what was it called, 314D. I can't remember what the nomenclature for all the federal funding was back then, but we got some federal funding. We got the National Health Service Corps in, and things started to stabilize. That's about when I went off to graduate school, decided I wanted to do health administration. And then it kept growing from then. Right now, it's probably got about half a dozen locations. They have mobile dental services, clinic services. They're expanding mental health services right now. I don't know, did Ron say Kelly was on? She could actually do an update on where they are right now if she's here. But anyway, that's a early story of how we got started. But it really was a community system evolving activity that put us all together. So we all had to work together, do everything with each other's programs, help each other out, and it worked out really well in the long run.
So, Bruce, thank you for that. Really, I think very clear chronology of how that system evolved. Let me reflect back and correct me if I'm not hearing some of the details, because this is the confluence of a number of opportunities. The first is that the community was being driven to organize because of these environmental factors. You had the highway coming through. Of course, you'd earlier had the concentration camps and the Japanese being displaced. You had the kingdom being built. So the community was being pressured. That alone was enough to get a lot of community activity. At the same time, you had people like you and others, and not just in the International District, but elsewhere, recognizing that there was a real need for healthcare to be made available to communities. So with the pressure on the community, and then there were these others who had the vision, like you, to create a health system, and that came together. And what I'm seeing is a reflection of energy, a synergy, actually. So it was the community, it was the people who had the vision, and then ultimately it was a gathering, not just of the International District folks, but all around the county, bringing these different communities together, all recognizing that they wanted to build effective health systems for their communities. So that, and then ultimately, because you had built a system, you had an infrastructure in place, now you're able to also pursue those extra funds, both
Mhm.
Medicaid and the National Health Service Corps, and ultimately other funds which have come to support community health centers nationwide. So
Correct.
it seems to me that it was a confluence of all of these opportunities. And I'm just reflecting on this because, of course, we're trying to move today beyond primary care. That is available, still a challenge for many communities and for many individuals, but we're also trying to make sure that everyone can have access to the full range of health care. And that's going to require a change to the healthcare system more globally.
Mhm.
But it seems like the same lessons are learned from what you did and need to apply today. You already answered one of my questions, which was going to be, how did the community respond? But uh, and you also answered that question that I had. What were the connections ultimately to government and to other organizations, other communities, other nonprofits? But maybe you could expand a little bit more on that because today we are seeing challenges to the funding in a lot of ways. I mean, we're looking at challenges to Medicaid. We're looking at challenges to direct funding to the community health centers. The National Health Service Corps is at great risk. So, what would you say are the lessons that you're reflecting on today, and how do we respond to those challenges today?
That's an excellent question. I think it's one of the things I'm in my hobby. I'm trying to get groups of, cooks and chefs together to work together to do some fundraising for a variety of agencies and services. Um, but if I go back in time, when the clinic started, for some reason, community was community. We all had a common population and some social issues to deal with, and uh, bring bring some services and solutions to. But we all work together through different agencies. I helped build the community garden, Asian counseling and referral services. We started up in this Bob Santos office, so we were helping each other. Chinese information services targeted specifically with one group. So we all kind of built the community system together. And then, so once that was developing and strong, what I did was moved into the other system to try to bring, the community health centers together. I think we all struggled with the same issues. We've got community health centers, but where are we going to refer, patients who need some specialty services? That was a big deal, and it was very hard. Um, but when we could figure out and talk together, in a collaborative organization from Central Seattle, we had a little bit more leverage. We got a little more attention. Um, we ended up finally getting services out of the University of Washington through Harborview. That was the main place. We've continually fought with, at that time, it was Polyclinic and Swedish Hospital. But I mean, that has turned around now too. So yeah, I guess it's, to me, it's kind of like system building around some issues. Figure out who's involved, find your common issues, and work together. There's places that where we disagreed on the strategy. So a lot of the clinics are starting to know we don't want any federal dollars in our program. We don't want to be independent from that. Okay, so we had to try and work out some ways of approaching that. Um, and then sort of the strength of the building of the international district clinic was that after the Vietnamese resettlement, there were other immigrations from Africa, Eastern Europe. So they've expanded into that arena too. I think we covered about, I think it was 9 or 10 different Asian languages or dialects. Now they're going to have staff that can support, I think, around 50 languages. So um, they found a niche where things work together and built upon that.
Well, Bruce, you and I have both worked in primary care and in public health, and we see the nexus between those two. They're not different organizations, they're part of a spectrum of
Yes,
securing care for the community. Today, we are seeing serious challenges to public health, and ultimately, I expect to see the same serious challenges to primary care.
right.
I'm wondering, um, the lessons that you learned about community organizing in the past, how are we going to take advantage of those lessons today to address these current issues? As an example, um, if there are cuts to the National Health Service Corps, which is a federally funded program, it's fully federally funded. It really doesn't get any state or local funding. Uh, how do we address those kinds of losses to our communities? I mean, are we going to have to pull back, or do you see that there's a different kind of organizing we're going to need to do into the future to really restore or at least to sustain what we've already got?
Uh, Hard to say. I don't think I have any solutions. Trying to, I think, build relationships with organizations and then figuring out how you're going to accomplish it. Like I said, we started out with the university this past year. I think I had to admit that my Medicaid Advantage is something that, 50 years ago I would have been ticked off about with United Healthcare and Optum. But International Community Health Services has actually been working with Optum now and to work on their quality of care strategies. I got Optum to contribute to the annual um, fundraising effort, dollars to community health centers, our community health center. I'm always pushing to try to get relationships developed between public health and um, community health. In my mind, community health is public health. I think it takes a while to train the primary care providers on what they're doing. It goes beyond seeing patients. And I think um, public health has to understand, well, they're not the provider for everything. So, there was early competition in Medicaid for all of that. Some of the Medicaid dollars was a way that public health um, had to use for funding. Well, that was probably the wrong thing to do. They needed to do what they're supposed to do and get the local financing together and then support the strategies that community health centers have to do to get their funding. So by pointing out, doing the epi analysis of their communities, helping them make the arguments for what's going on. Um,
So I think you're hinting at something that I've often thought about, which is the responsibility of healthcare providers beyond the clinic.
right.
And I think there is a real recognition, especially from community health centers, that it's more than just providing the clinical services. It's
Mhm.
also about what's happening in the community. And of course, public health historically has been responsible to some degree, as resources permitted, for what's going on in the community. We think about infectious disease prevention and environmental health issues, but community health centers and primary care providers also are responsible for things like how do we assure the housing? And it's not just, as a primary care doctor, I'd never be able to give someone access to housing directly. But community health centers are recognizing that that's really important. If you want to get
Mhm.
someone healthy, it's not enough to just give them the medicine and kick them back out on the street. They've got to have a
Right,
place to go. So
right,
doctors and other healthcare providers also have a political responsibility to organize and to be loud voices advocating for those kinds of additional services. And when you
right.
say building the relationship, absolutely. Public health needs to be working with the community health centers on precisely those kinds of issues so that it's a collective voice. So,
Yeah. I totally agree. It's not directly related, but It's how public health can sort of push an issue. Um, Back in the 80s, when I first started the health department, I was a manager of the jail health services. And there was one year where we had a rash of suicides and one homicide in the jail. And I talked to John Kobayashi, who is the state epidemiologist, and said, can't we call this an epidemic and sort of look at what's going on and sort of begin assessing
Uh-oh, you froze. Bruce, can you still hear us?
enough? There's other issues associated, but there's no discussion about what areas we should be focusing on: drugs, education, mental health, whatever, education, amongst the homelessness problem. So it's basically, for me, it's like an epi analysis. Figure out what's going on, what are the risks, and figure out, what you can do about each component of that as your system strategy. And that's where I think community health centers can play an important role in some of those community issues. Figure out where they sit in it, but they have to understand the dynamics of the whole system first.
Which is exactly why public health and primary care need to work so closely.
Mhm,
And it's why we need a universal healthcare system that's not just about how we fund medical
mhm,
services, but truly universal health care, which
mhm,
is looking at the full range of the social determinants of health as
mhm.
well as the medical elements of health.
Sure.
So, all right. Well, Bruce, I think that I've exhausted you, perhaps, and now we wanted to open it up to some questions. So I'm going to turn it back to Ronnie and to the others who are monitoring the chat room, and they can guide us on the questions. Ronnie.
Yes. So thank you, thank you, thank you. If we could let Gary and Bruce hide for a second and take the spotlight off of them, that can take a few minutes to go through the chat. Uh, Please also, if you add questions in the chat, feel free to do that at any point. We've entered the website that you can go and make a donation or volunteer to help us out or to offer your opinions. So please take this opportunity to do that. Funding for Healthcare for All Washington allows us to help implement changes. We certainly do have a communication specialist that shares the work we're doing with each of you. And we have a lobbyist who works with legislators, but also, and just as importantly, supporting government agencies that have to implement the changes that come out of our ideas, that come out of our lobbying. So the more, if you are able to make a donation, the more we can do that, the more likely we are to move along that pathway. We've had great success with people in the Healthcare Authority and the Department of Health and the Health Benefit Exchange in implementing the changes that we've formulated in our minds. But there is a role, as we talked about, more than just simply funding, a role in identifying that there has to be a certain amount of primary care paid for by our insurance premiums. There has to be an outreach to communities that have a greater need. Health equity is not just about providing the same service to everyone. It's providing the service that is needed by that community. Uh, our example tonight of the Asian and Pacific Islander population is a critical one, but it also holds true for LGBTQ, for Hispanic, for people in different working environments. So the more we can support government in creating and supporting an opening for organizations to do that, the better we can move along that pathway. And we talked about, Bruce alluded to the role of insurance companies and and of larger institutions that are building up. We want to take the pure profit motive and get them involved in helping to build the community and to doing the right thing in the community. So coming up with those ideas, working with our organization to do that, and supporting us in working with a role for government agencies and for politicians to who have great ideas, but they have to be implemented. That's the real work that we're focusing on right now. So thank you for any donations and the donations you've already been able to make. Thank you, each of you, for participating in that. And now let's go into the Q&A and pull out some of those ideas. If we could highlight John Sobeck, who is a volunteer with Healthcare for All. Thanks, John, for joining us. He's
Sure.
a OBGYN who has seen a lot of different levels of government roles, of how the rest of the healthcare system works and how that can support primary care. Uh, so John or Gary or Bruce, is there a first question that you would suggest we start with?
Well,
We have
actually,
a few. Yeah, go
there
ahead,
were,
Bruce. Sorry.
yeah, there
Well,
were,
I just see one question in there. Hi, David. David Loud. He brought up a question about the symbiotic relationship between the community health centers and the U.S. Public Health Service Hospital after 1971. Well, sorry I didn't cover that, but that was really important too. I think I mentioned talking with country doctor Tom Byers was a strong leader in all of this, and getting the National Health Service Corps in and really working with the Public Health Service Hospital. We actually used them for a lot of uh, specialty services back in the time. And eventually the city took over the building through a public development authority. And sort of added resources and functions to the community health center system.
so there are a couple of other questions that Bruce may be able to answer to some degree, but I'm also wondering if as Bruce was mentioning, there may be others who are closer to the current operations of the ICHS. So one of those questions is about the National Health Service Corps and its current potential. And then another question was how dependent on federal funds is the ICHS and what will be needed to preserve services to the community? I'll defer to Bruce to decide to what degree he can answer those.
Well, Reagan killed the National Health Service Corps positions that came to the city. So that started up and then left. We actually had some positions for the jail health services too. But I think when they tightened up that first round with Reagan, then those positions disappeared. They were primarily intended, I think, for low manpower shortage areas. That's the definition. And that tends to be mostly some of the rural areas or communities. I don't know the current proportion of federal funds for the clinic right now. I don't know, Ron, you said Kelly might be on?
I don't see her at this point.
Okay. Yeah, so right now at the current stage, I don't know what the proportion of federal dollars are there. Early on, it was very heavily donations and grants. And I don't know if some of you go back far enough to know the CETA program, the Comprehensive Employment and Training Act. There are positions that were given to a variety of agencies, and you can use them for a variety of activities. And we relied on those positions too.
I have a couple other questions. Describe outreach to make sure that vulnerable populations seek care in your current model. You know, cultural differences, whatever.
Um, it's mostly positioning in communities, clinics in communities that they know they've analyzed the population, and there may be some potential care available, needs available in that area. We also have mobile vans that move around and can identify potential areas. Uh, Word of mouth, I think, is generally what's going on. There's association with the various um, religious entities or community clubs or whatever. They start programs. They run a couple of school-based clinics, and I think that develops some attachments to the clinics. So there's a variety of outreach activity going on.
And you mentioned something a little bit about working with some of the other clinics like Polyclinic and what have you. Can you discuss more about how you work with medical groups to either donate care or offer access at low Medicare rates?
Well, I think physicians that come in, maybe nurse practitioners too, come in and try to initiate some conversation with the groups locally. That's really about it. And try to make some, identify some personal contacts. Um, Polyclinic, for example, was administered by a person who's a friend of mine from the clinic days. He ran planning at Harborview. So, and then he migrated to Polyclinic's chief executive officer, and so made sure there was some connections there.
Though the Polyclinic's not traditionally been a big Medicaid
No, they don't
provider.
participate. No, they do not.
Right.
Polyclinic was the big problem back when we were opening the clinic,
Yeah.
and Swedish Hospital. And it was actually an issue. When I was growing up, I don't remember if there were any Asian physicians that were allowed at Swedish. I don't think they were given privileges. All the Asian docs had privileges at Providence. And then my pediatrician, for example, was Chinese, and he wasn't allowed into the King County Medical Society, so he practiced with group health.
Wow.
Maybe you can explain a little bit, maybe more creative ways you get funding for other non-traditionally medical covered things like social determinants of health. You mentioned a little bit about housing and stuff. So, I mean, are there other funding mechanisms you use to make sure people are getting all the things they need outside of traditional, ICD-10 based care?
You mean you haven't been invited to any of the annual galas for these organizations? Literally, for the ICHS annually, this year they had a lunch. They've had annual dinners after 50 years, and they do auctions and get people in. That's part of what I've been trying to do with this food hobby that I have, is help do some foodie oriented fundraising projects for agencies. I've run into a very young group that's they've, young professionals, they have money to spend. They're trying to look at services and doing something to attract their involvement in organizing. And I just happen to think these food events tend to be big deals with them. So there's a lot of big promotions in the city, for example, that Taste of Washington wines, Bite of Seattle, those sorts of events. Well, those are all for-profit, um, you know, activities. They're big businesses that run them. They take advantage of the chefs and the cooks and the food. Taste of Washington, for example, I was volunteering with the chef I work with, and they give her 75 cents per serving, and they sell admission at $250. So there's some, if you work some organizing things, you both educate the community on, what kind of services are there. You have an opportunity to raise some money, and you can do some communication. You can get some large agencies or physicians groups or insurance companies to help participate. I think we have a lot of staff that would be interested in that, at least to start the relationship. I don't know how productive it will eventually go, but you got to have the relationship before you get the money.
Good. All right, another question is, I'm working to get a national voice as nurses and nurse practitioners, but not really successful. How would you direct me direct me to get our cohort to get public messages and education on the link between the budget bill and denying patients care?
Ooh, that's an
It's
interesting one.
a tough one.
Are there any, I don't know, are there any community health center nursing organizations? There needs to be some way to cut out if community health centers could sponsor, in a region or area, a nursing group um, to come together. I think that's the only way you can do it.
I think another part of that question is how do we take advantage of the non-physician workforce that can do a lot of good in this community?
Well, I don't know. If they're not getting together, they can unionize somehow. That's another way.
All right, another question is there any focus on elders in the clinic?
That was the main driver for International Community Health Services. It was a elderly population in the international district, sort of hotel bound mostly or tight. Right now, in fact, today I was at the Filipino Community Center looking at ways to collaborate. They're building some senior housing and talking with International Community Health Services about putting a clinic in that housing facility. There's a large housing facility just below Pacific Medical Center, and there's a senior, ICHS has a senior health program built into that. So they fit together.
This might be a little provocative question. This is coming from me. I worked for Optum Care of Washington for a couple of years, so I know a lot about United and Optum and their ability to maximize risk adjustment in the senior population. So
Uh-huh.
outside of like maximizing the risk adjustment and the funds associated with the senior population, and I know that the ICHS has a fair number of Medicare population. How do you work with Optum to make sure you're getting what you need from them, other than them just kind of maximizing their reimbursement from Medicare?
Well, I guess it's watching them, working with them on our quality improvement programs, that they see what's going on and hopefully they get a feel for the services that are required and what they could need. Maybe it carries over, but I I just felt lucky to get my position to submit a request that got acknowledged to get a donation to the program.
Good,
They did.
thanks.
They did show up to the event. So they brought 5 people: the chief executive and quality improvement guy, and a couple of other folks. So the relationship has started. Um, I don't know how much is going on, but there is a relationship now.
Great, thank you. Is there any questions that people didn't get asked and answered?
And so I think one of the things that community-based clinics can do to support healthcare providers and nurses and staff is sponsoring people within their own community. I think that's some of the examples you shared with us tonight, Bruce, is how it was people within the community that made the International District Clinic expand and
Mhm.
grow and become involve more other people in the community. But the same thing is true for providers. There are fundraising events that sponsor nurses to to finish their or supplement their degrees and to come back and work in the community. We are so fortunate to have organizations like that in our in our community, and certainly the International District has been a plethora of different organizations that have popped up and reached out to nurses or docs or physician's assistants in order to support them to return to the community. Uh, so I think that's an important issue. And it's one of the issues that Michael Fine spoke about last month is, can we identify people within the community to go to school and return and continue to work in the community? And he did ask Bruce and Gary and I a question about a particular person that he was looking for who had been supported by their community in Washington, had gone on to medical school and returned to work in a community organized, a community-based clinic. Uh, he said the name was Fran Yuhis, Yuhis. So this is a question for people out there. If you do know of a provider with that name, please get back to me at Healthcare for All or one of our board members and tell us, and help us connect this National Primary Care Organization with a great example, a great story. And that's one of the things we are working on. Uh, it's a frustrating time politically, and this happens to be a threatening time for Medicaid. But one of the key things we can do right now is share those stories publicly, either through writing in op-eds or by directly contacting legislators. So stories like Bruce is sharing tonight can have a real impact on our future and on the future of our communities. So I want to thank you all. Thank you, Bruce, for coming out of the restaurant for a night. Thank you, Gary, for taking the time to work with Bruce and us to really develop those questions. Thank you, John, for taking a lead role, and to the uh, people behind the scenes, to Ron Lovell, Rich Legoo, and D.W. Clark, who are supporting us tonight in the background, and to people on our volunteer committees, our communications committee, like Marcia and Sydney and Ron and Connie and John again, Carl and Conlin. Thank you all for the contribution you're making behind the scenes to get us all together to have that opportunity to talk about creating democratically based community health centers. So let me know if you want to join us, and thank you very much for joining us tonight, and have a pleasant tomorrow.
Hey, Ron, let me make a quick comment about volunteering. So I started volunteering about 3, maybe 4 months ago, and there's a lot of room for people with backgrounds in education and things that they can contribute. So even though I'm a fairly recent volunteer, I've gotten involved in policy committee and communications committee and social media. So there's a lot of room, and a lot of people who volunteer are going to sit around with nothing to do. We have lots that we can give them and lots that we can have them share to contribute to the organization. So if you're thinking about volunteering, think about becoming a very active volunteer, because those who volunteer, we have a lot that we can offer to you to help, and a lot you can offer to help us.
Well, thank you all. Thank you, John, for those closing comments. Have a great evening.
Yeah.
Good night.